Welcome back. In this talk, we're going to go over the preoperative assessment of the surgical patient. This is a really important phase of surgical care. It allows us to accomplish several important goals. The first is that it allows us to have a meaningful discussion with our patients about risks and benefits of the proposed procedure. The second goal is that if medical risk factors can be optimized, then we should see fewer postoperative complications. We'll begin by going over a general medical evaluation of a surgical patient. We'll then talk about laboratory assessment, and finally we'll spend a fair amount of time going over risk evaluation. Specifically, we'll talk about cardiac risk, pulmonary risk, and liver risk factors that are relevant in our patient population. The goal of the preoperative assessment is to identify and quantify any comorbidity that may affect the operative result. Importantly, the goal of the preoperative assessment is not to screen for undiagnosed disease in an asymptomatic patient. In other words, the preoperative assessment is much more about addressing known problems and much less about trying to find new problems. In the United States, as well as other parts of the world, the number of patients who are living into their 80s and 90s is increasing rapidly. And so we should certainly expect to see more and more of these patients in our offices with surgical referrals. Now, age, in and of itself, is only a very minor component of preoperative coronary risk assessment. Age, however, does appear to be an independent risk factor for postoperative pulmonary complications like pneumonia and increased time on the ventilator. One challenge with working with age is that it's very difficult to separate age from many other comorbidities that also increase with age. And so we see patients with cognitive impairment more frequently in the older age groups. And the same with malnutrition, particularly protein malnutrition. Now, frailty is a relatively new concept in the surgical world that's designed to take into account more the patient's physiologic age rather than their chronologic age. And so frailty is about looking at the patient's medical condition and seeing what medical comorbidities they have. And so it makes perfectly good sense that the more comorbidities you have, the greater your surgical risk would be. And so I think this is a very reasonable way to approach the problem with age. A patient can be 85 and very robust with minimal comorbidities, and their surgical risk should be perfectly acceptable. On the other hand, we occasionally see patients in their 50s and 60s who have multiple medical comorbidities, and so their risk may well be prohibitive. During your preoperative assessment, you are definitely going to want to ask your patient about their exercise capabilities. Patients who are physically active overall have a lower perioperative risk. This chart shown here lists several common physical activities, and the unit of measure is the MET, or metabolic equivalent. And so if you're sitting down just watching TV, you're expending 1 MET. If you can walk at a brisk pace, then you're expending close to 4 METs, which means that you're expending 4 times the energy than if you were just sitting down. This 4 MET number is pretty important because if a patient can exercise several times a week at this level of activity without getting symptomatic from a cardiac or respiratory standpoint, then they're not going to need any further cardiac evaluation. In effect, the exercise they're doing is their own personal stress test. Do ask patients what medications they're on. Better yet, ask to see a list of the medications they're on. I'm always surprised that when I ask patients how their overall general health is, a very common reply is that, well, it's really good, pretty good, doc. And then when I look at their medication list, I find out they're a diabetic and have hypertension and take a statin, et cetera, et cetera. And so I guess the moral of the story is trust the patient, but verify and take a look at the medication list. As surgeons, we're going to be particularly interested in drugs that affect clotting. I'm not going to go into any detail today on these drugs because there's a whole video out there that I made on this very subject, so it may be worth your time to review that. Also take note if the patient is on beta blockers. We'll talk about beta blockers in a little bit in this video, but suffice it to say for now, if they're on beta blockers, we're likely going to want to continue those through the perioperative period. A nutritional assessment of any potential surgical patient is really important. Patients who are malnourished don't heal their wounds well. In addition, they have a higher incidence of many postoperative complications. A history of a 5% weight loss in a month is clinically significant, as is a 10% weight loss within 3 to 6 months. Patients with very low BMIs are likely malnourished, but obesity is not protective of malnutrition at all. Obese patients can have protein malnutrition and they can be deficient in important vitamins and minerals. Some of the signs and symptoms of malnourishment are reduced appetite, fatigue, weakness, cold intolerance, and physical findings might include loose skin, loss of muscle mass, and even frank cachexia. We used to use albumin, prealbumin, and transferrin as serum markers of malnutrition, but these are no longer felt to be reliable. Unfortunately, in affluent countries, obesity is an epidemic. Patients with a BMI greater than 40 have increased mortality in the postoperative period. Obese patients also have many other comorbid conditions that increase their risk. Many of them have high blood pressure, ischemic heart disease, congestive heart failure, diabetes, and obstructive sleep apnea. Obese patients also have a greatly increased risk for DVTs and pulmonary embolisms. Lastly, they have many more wound complications, including wound infections and dehiscences. We've only recently begun to realize that obstructive sleep apnea is an important cause of postoperative morbidity and mortality. Patients with sleep apnea have an increased risk of cardiac arrest, hypoxemia, frank respiratory failure, and the need for reintubation. The thing about sleep apnea is that most patients are undiagnosed. It makes sense to ask a spouse or roommate if the patient is a particularly loud snorer or if they have periods of time where they stop breathing at night. I think it makes sense to consider screening high-risk patients. The reason to screen these patients is that there are interventions available, like a CPAP mask, that will help. and this would reduce postoperative complications if we can diagnose the problem up front. All of our patients should be queried about their use and abuse of alcohol. Heavy drinkers have an increased risk of postoperative complications, including a higher rate of surgical site infections and a higher risk of cardiopulmonary complications. Of course, alcoholics may well have underlying liver disease, and in the perioperative period, acute withdrawal can be a difficult and dangerous problem to manage. All of our patients should be counseled to stop drinking, but the optimal period of cessation is unknown, but should probably be at least 4 weeks. Besides alcohol use, we have to specifically ask our patients about chronic opioid use as well. The number of patients who are taking these drugs has exploded over the last 10 to 15 years, and it's literally an epidemic in the United States. These drugs may be legally prescribed or illegally obtained. One big issue for us as surgeons is post-op pain control, and with the chronic opioid user, this can be exceedingly difficult. Oftentimes, these patients will tell us that certain common drugs like morphine and Dilaudid don't work for them, and they might only want a specific drug like fentanyl. This presents us a problem because in many hospitals, a drug like fentanyl cannot be used in an unmonitored setting like a general surgical floor. Another issue is dosing. Many of these patients ask for and require very high doses. Doctors are often uncomfortable prescribing narcotics at these doses, and nurses are often uncomfortable administering them at these doses. Another potential problem is acute withdrawal. Not every patient will tell us they take opioids, especially if they're doing it illegally. So we need to be on the alert for acute withdrawal symptoms. If you're fortunate enough to work in a facility with a good pain management specialist, do yourself a favor and consult them. They can be very helpful in managing a difficult patient. Another issue that we need to bring up with our patients preoperatively is smoking. Smokers have a much higher rate of postoperative complications. They have poor wound healing and a higher incidence of wound infections. They also have more postoperative pulmonary complications like pneumonia and respiratory failure. Their incidence of MIs and strokes is also significantly higher. Now, if it's an emergent or urgent case, then there's really nothing we can do about their smoking. But if the case is a purely elective case, we should strongly ask our patients to stop smoking, and we should be willing to provide resources that will help facilitate that. If our patient tells us that there's no way they can stop, then they at least need to know that their risk of postoperative complications is much higher than a non-smoker's. So the preoperative medical evaluation is all about identifying problems that can affect the outcome of the procedure. And so there are really two goals here. The first is to identify problems that could be improved, and the second is to allow us to have an honest discussion with our patient about risk versus benefits. Because at the end of the day, this entire preoperative process is about making sure that the potential benefit of a procedure is worth more than the potential risk. So now let's go on and talk about the preoperative lab evaluation of our patient. The purpose of the preoperative laboratory evaluation is to identify abnormalities that will affect the conduct and the postoperative course of the operation. And so if you're going to order a test, there should be a clinical indication for that test. As an example, if a patient is asymptomatic and you order a urinalysis, you have to ask, well, what will happen if the test is positive? Most positive UAs are because of a poorly obtained specimen. But now you're going to be obligated to follow this up with a clean catch specimen. This ultimately will delay the procedure and increase the expense to the system. So just order a test if you care about the results. So which of our preoperative patients should have a CBC done? First of all, anemia is very rare in asymptomatic patients. And so we should ask our patients about undue fatigue or whether they're orthostatic. And if the answers to these questions are no, then it would be very unusual to find a low hemoglobin on the CBC. There is, however, one caveat to this, and that preoperative anemia is a predictor of postoperative mortality. And so as patients get older, they often are less active, and so the symptoms of anemia can be more difficult to detect. And so I do think in patients who are 65 or older who need a major abdominal or intrathoracic procedure, I think in these patients a baseline hemoglobin is entirely reasonable. As far as platelet counts go, if a patient has no bleeding history, it would be exceedingly rare to detect an actionable low platelet count. For many of our patients, we are going to want to know their baseline kidney function. Mild to moderate kidney disease is common. It is largely asymptomatic, and it increases with age. We're going to want to know our patient's kidney function because a creatinine greater than 2 is an independent risk factor that predicts cardiac mortality. Also, renal insufficiency will influence drug choices and may require dosing adjustments as well. And so patients who are over 50, who are to undergo an intermediate or high-risk procedure, should probably have a baseline BUN and creatinine drawn. Unsuspected electrolyte abnormalities are distinctly unusual, and so routine measurement of the patient's sodium and potassium is not necessary. However, if they have renal disease or if they're taking medicines like diuretics that will affect their electrolytes, then of course we would want to know that information preoperatively. It is not necessary to measure a glucose level in a non-diabetic patient. However, if the patient is a known diabetic, we're definitely going to want to know how well controlled they are. Patients with hyperglycemia in the postoperative period have increased infectious complications, and so knowing their glucose level pre-op will help us design an appropriate post-op glucose strategy. Liver function tests only need to be ordered if the patient has known liver disease or if liver disease is strongly suggested by the history. Let's say the patient has a history of alcohol abuse. Likewise, coagulation tests only need to be ordered if the patient has a known bleeding disorder or if they have a history of liver disease or if they're taking an anticoagulant like Coumadin. Pregnancy testing is mandatory in all women of reproductive age. Women in the first few weeks of pregnancy may not even know they're pregnant yet. It's important to know if someone's pregnant because pregnancy will certainly alter surgical decision-making and management. EKGs are not indicated in healthy asymptomatic patients who are undergoing low-risk procedures. However, most operating rooms will require them for patients who are over 65 years old. One major issue with EKGs is that abnormal studies with little clinical significance are quite common, but they may require expensive follow-up studies just to rule out any significant pathology. Chest x-rays should only be ordered in patients who have a history of cardiopulmonary disease or who currently are symptomatic from a pulmonary standpoint. The problem with routine chest x-rays is that abnormal findings like granulomas are very common. If there's no previous chest x-ray to compare to, then the radiologist may well recommend a CT scan and potentially even a biopsy as follow-up to this x-ray. After we finish the preoperative medical and laboratory assessment, we often find that we need to drill down much deeper into specific risk factors. We'll start off by taking a detailed look at cardiac risk evaluation. As a baseline, in patients who are about to undergo a major operation, if they're over 40 years old, even if they don't have any known cardiac risk factors, the chance of a perioperative MI is about 1.4%, and the chance of suffering a cardiac death is about 1%. Of course, these numbers jump up if there are known cardiac risk factors, with the MI rate about 3.2% and the risk of cardiac death about 1.7%. Major surgery is stressful and predisposes patients to myocardial ischemia. Big operations can be associated with large intravascular volume shifts and sometimes major blood loss as well. In the postoperative period, elevated catecholamines increase myocardial oxygen demands, and postoperative anemia may limit the patient's ability to deliver this oxygen. Because surgery is inherently risky, it is critical that we identify patients with pre-existing cardiac risk factors, since these risk factors will greatly add to the baseline cardiac risk. If our patient has known or suspected cardiac disease, we are going to need to be compulsive in our history taking. We specifically want to ask about chest pain, and if it's present, when is it present? Is it at rest, or does it occur during some degree of exertion? We're going to want to know about shortness of breath. I find a useful question to ask is, how many pillows does the patient sleep on? If the answer is more than 2, that may well point to a problem. Syncope and palpitations suggest an underlying arrhythmia. We will also want to delve into medical conditions that increase cardiac risk. So we want to know about any previous MI and whether the patient has cardiac stents or has had coronary artery bypass surgery. We will want to know as well about diabetes, chronic kidney disease, and a history of TIA or stroke. As we'll see in a few minutes, all these medical conditions can be put into an easy-to-use cardiac risk calculator. Assessing functional status is nothing more than trying to understand our patient's day-to-day activities and what kind of limitations they might have. And so if our patient is active and vigorous, then they have a lower risk of cardiac complications. On the other hand, if our patient is unable to climb 2 flights of stairs or can't walk a half a mile without stopping, they're definitely going to fall into the higher risk group. Although a basic cardiac exam is part of the preoperative assessment, it is especially important in our patients who are poor historians or in those patients who can't give a history at all. Important findings would be murmurs, pedal edema, or poor quality peripheral pulses. Any patient with cardiac symptoms needs an EKG. Important findings to note include arrhythmias, bundle branch blocks, abnormal Q waves, or ST segment changes. If any of these are present, usually it will require a referral to a cardiologist for additional evaluation. Besides the patient-specific risk factors that we have been discussing so far, the type of surgery to be performed is also an independent cardiac risk factor. High-risk procedures include aortic surgery or any major open vascular procedure, and they have a risk of non-fatal MI or cardiac death that is greater than 5%. Intermediate risk procedures include laparotomies and thoracotomies, and their cardiac risk is between 1 and 5%. Low-risk procedures include the common outpatient type surgeries. This would include hernias, breast surgery, and endoscopies, and the cardiac risk associated with these procedures is substantially less than 1%. After doing a basic cardiac history and physical exam, estimating perioperative cardiac risk is very straightforward using the revised Goldman Cardiac Risk Index shown here. There's 4 clinical criteria that should be easily obtained by your history and physical. These include the presence or history of ischemic heart disease, congestive heart failure, insulin-dependent diabetes, or TIA or stroke. Only one lab value is required, and that's the creatinine. And so a creatinine level greater than 2 is important. Lastly, high-risk surgical procedures are part of this index as well. And so if any one of these features is present, you get a point, and then the points are summed up to put you into a risk category. The chart shown here allows you to group your patients by risk factors. And so if you have 0 or 1 risk factor, the risk of a major cardiac complication is 1% or less. You can see as you get to 2 risk factors, however, the risk jumps up to 7%, and for 3 or more, the risk factor is 11%. Once we know our patient's cardiac risk score, then the next decision to be made is whether additional cardiac testing is necessary. Now, certainly low-risk patients require nothing more, but many of our intermediate and high-risk patients will require an additional workup. If the patient's history and exam suggests coronary artery disease, then the first test recommended is usually a treadmill stress test. If the patient does particularly poorly on this test, then it's possible they'll need a coronary angiogram, which may ultimately lead to the recommendation for cardiac stent placement or even cardiac bypass surgery. If the patient's workup suggests that they have congestive heart failure or valve disease, then an echocardiogram is usually the indicated test. This test is able to quantify how well the ventricle works by calculating an ejection fraction, and it can also calculate the degree of valvular stenosis or regurgitation. Lastly, if the patient's history suggests arrhythmias or syncopal episodes, then a 24-hour cardiac monitor is usually the next step. If the cardiac evaluation reveals a critical coronary artery stenosis, then some type of revascularization will be necessary for the patient's overall general health. But interestingly, there is no evidence that revascularization ultimately improves the surgical outcome. If our patient has had a recent MI we need to wait at least 4 to 6 weeks before we operate. If the patient has a bare metal stent placed, then we need to wait at least 30 days before we consider operating. If they have a drug-eluting stent placed, then ideally we would wait 1 year before proceeding. The use of perioperative beta blockers has a controversial history in general surgery. After a major operation, the sympathetic nervous system is activated. This ultimately leads to effects on the heart, which include tachycardia and increased contractility. Although these effects overall are beneficial, they do come at the price of increasing myocardial oxygen consumption. Now, patients who have coronary artery disease have fixed obstructions in their coronary vessels, and so they can't necessarily increase blood flow to keep up with the increased myocardial oxygen demand. This ultimately can lead to myocardial ischemia. And so the rationale for using beta blockers in the perioperative period is to damp down this sympathetic response. Beta blockers also have the effect of inhibiting platelet activation and inhibiting the formation of microvascular thromboses. This can also help prevent clots from forming in the coronary arteries. So overall, it would appear that beta blockers are a good thing in the perioperative period. And they definitely do decrease cardiac mortality. However, and this is a big however, beta blockers increase stroke mortality. And so when all this is added up, the routine administration of beta blockers is associated with an overall increased mortality rate. This was first demonstrated in the POISE clinical trial and has been confirmed at least several more times. And so where does that leave us? Well, the current recommendations for beta blockers would be to continue them if the patient has been taking them preoperatively. Patients who are low or intermediate risk should not be started on them. And they can be considered on a case-by-case basis for high-risk patients, but this should be done with the advice and counsel of a cardiologist. Let's now move on and talk about the pulmonary evaluation. There are multiple risk factors for perioperative pulmonary complications. Clearly, the type of surgery is important, and patients who are to undergo an upper abdominal procedure or thoracic procedure have the highest risk of pulmonary complications. Some of the more general risk factors include older age and poor functional status. Patients who've undergone significant weight loss and who are malnourished also have a much higher risk, as do severely obese patients as well. Some of the specific pulmonary risk factors we'll want to ascertain include the presence of COPD, asthma, or dyspnea. We'll surely want to know whether the patient is a smoker or not, and whether they have sleep apnea or not. As a result of our pulmonary risk assessment, some of our patients will require further pulmonary testing. Besides any patient who's found to have significant pulmonary disease by history or physical exam, any patient who's due to undergo a major lung resection, like a lobectomy or pneumonectomy, will require pulmonary function testing, as will any patient who's due to receive single lung ventilation anesthesia. Although there are a myriad of pulmonary function tests available, the ones most commonly used as part of a preoperative assessment include the FEV1, the forced vital capacity, and the diffusing capacity of carbon monoxide. Of these three, the FEV1 is the best predictor. The FEV1 represents the proportion of vital capacity that a patient can expire in the first second of a forced expiration. And so any patient who has an FEV1 of less than 30% has very significant underlying pulmonary disease and a very high risk of postoperative pulmonary complications. Of course, the goal of the preoperative assessment is not just to quantify risk, but also to identify patients who might benefit from specific preoperative interventions. And so we might find that some of our patients benefit from a short course of bronchodilator therapy. Severe or poorly controlled asthmatics might benefit from a course of steroids. All smokers should be strongly encouraged to stop. One of the best things a patient can do, if they're physically able, is to walk several miles 3 or 4 times a week before their procedure. And lastly, in very high-risk patients, we may decide to do the case under a spinal or epidural anesthesia, which have less pulmonary complications associated with them. We take care of many patients with moderate to severe renal disease. These patients are extremely complicated because renal disease is usually associated with many other significant comorbidities. We've already seen that a creatinine greater than 2 is an independent risk factor for cardiac complications. And in addition to the underlying cardiac disease, renal patients tend to have electrolyte problems, and they have poorly controlled diabetes and hypertension. In addition, they're almost always volume overloaded, and they're anemic, and their platelets don't work very well either. There are a number of interventions that we can take to improve our renal patients' perioperative results. Their anemia will usually respond to erythropoietin. Volume status needs to be vigorously corrected, and this will be done either with increased dosages of diuretics or increased frequency and aggressiveness of dialysis. Most renal patients are hypocalcemic, and so they'll require calcium supplementation. Renal patients are also usually hyperphosphatemic, and this is managed with phosphate binders. We'll need to be very compulsive about correcting hyperkalemia. For our patients who are on dialysis, the optimal timing of dialysis is the day before surgery. Postoperatively, we'll want to avoid nephrotoxic drugs and use renal dosing where appropriate. One of our biggest challenges is managing the post-op volume status of a renal patient. There's such a narrow therapeutic window here. It is extremely easy to volume overload a renal patient, and this will likely result in congestive heart failure and pulmonary edema. On the other hand, too little fluid will lead to hypovolemia and poor organ perfusion, which is dangerous as well. Moving on, let's now talk a little bit about liver evaluation. There are 2 scoring systems in common clinical use that are designed to predict mortality in cirrhotic patients. There's the Child-Pugh score and the MELD score. The Child-Pugh score is an old system that was developed in 1964. And its initial use case was to guide selection of patients who would benefit from an elective portacaval shunt. We now use it in general surgery to predict operative risk following major abdominal procedures in cirrhotic patients. So in general, a Child A patient has about a 10% mortality following a large abdominal operation. We'll generally consider that to be an acceptable risk. On the other hand, the Child C patient has a 76% mortality, which we will usually consider to be a prohibitive risk. The Child B patients are the patients where difficult decisions have to be made. Their operative risk and mortality is about 31%, which is obviously very large. But some of these patients will do well. And so all decisions for child B patients need to be individualized and made on a case-by-case basis. The Child-Pugh classification is made up of 5 different variables. 3 of them are measured lab values, bilirubin, albumin, and INR, and 2 are observed clinical parameters, encephalopathy and ascites. One criticism of the Child-Pugh system is that the presence of these 2 clinical parameters allows for some degree of inter-observer variability amongst clinicians. In other words, reasonable physicians may disagree about whether someone has, grade 2 or grade 3 encephalopathy and whether there's mild or severe ascites present. The MELD score is the other common risk stratification tool that we use in general surgery. Initially, the MELD score was based on 3 measured lab values, total bilirubin, creatinine, and INR. But recently, a 4th value was added to the scoring system, serum sodium. The MELD score is designed to predict 3-month mortality in cirrhotic patients, and so its main use case is to determine priority on the liver transplant list. But since it's so easy to calculate, this score has found use in general surgery. As it turns out, we will rarely recommend operation on any patient with a MELD score greater than 20. Their risk is just too high. One situation that a general surgeon is likely to face is an elective referral for an umbilical hernia repair in a cirrhotic patient. Now, historically, most general surgeons have refused to operate in this situation, really for 2 reasons. The first is that the operative mortality rate is very high in this patient population, and second is that umbilical hernia recurrence is really common as well. However, as those of us who take general surgery emergency room call know, is that these patients also present to the ER with rupture of their hernia and massive ascites leak, and these patients will require emergency procedures that have an even higher mortality rate. So I'd say the pendulum has kind of swung to sort of a middle ground. It's reasonable to consider surgery in a well-compensated cirrhotic, but it's mandatory that you be able to control their ascites. This may require aggressive diuretic therapy with Lasix and spironolactone. It likely will require large volume paracentesis, and maybe even a procedure like TIPS to get the ascites under control. If the ascites is not manageable, then there's no sense operating because the recurrence rate will be too high. Now, even if the patient is well compensated from their cirrhosis, and even if their ascites can be controlled, the mortality rate may still be as high as 14%. But this is certainly lower than if they come to the emergency room with a ruptured hernia. Many cirrhotic patients have gallstones, and so they develop symptomatic cholelithiasis and acute cholecystitis. Most surgeons have learned the hard way that these patients are best managed non-operatively. This could be with antibiotics, or it could be with a cholecystostomy tube. Patients who have a pre-existing coagulopathy and portal hypertension can have torrential bleeding from the liver bed that's extremely difficult to control. And so avoiding surgery in these circumstances is usually best. However, if there is no other option but surgery available to this patient, the laparoscopic approach should be done if possible, since it's associated with less bleeding than open surgery. I'll finish off this topic by saying a few words about preoperative diabetes management, and perioperative steroid replacement. Diabetics present several preoperative challenges to the surgeon. The first is that diabetes does not exist in a vacuum, and most diabetics have multiple other comorbidities that we're going to have to identify and address. In particular, most diabetics have underlying cardiac and renal disease. The second issue is that diabetics with poorly controlled sugars have a much higher rate of postoperative infections. So in a purely elective case, we would like the patient's hemoglobin A1C to be less than 8. In the postoperative period, we strive to keep the glucose levels under 200 and ideally aiming for a level of about 150. For non-insulin dependent diabetics, we ask them not to take their morning dose on the day of surgery. They can then get back on their regular schedule once they're able to resume oral intake. If a patient is taking short-acting insulins, these must be held during the entire period that the patient is NPO. For the patient who takes intermediate or long-acting insulin, we generally ask them to take 1/2 to 2/3 their normal evening dose the night before surgery, and then half of the morning dose the day of surgery. All diabetic patients who come into the preoperative area on the morning of surgery need to have an IV started with a 5% glucose solution going. The reason for this is to prevent hypoglycemia. Diabetics who haven't eaten for a number of hours, who have taken even a smaller amount of insulin, do run the risk of a rebound hypoglycemia. Many patients are taking oral glucocorticoids for a host of inflammatory and autoimmune diseases. And so depending on the dose, these patients will have some degree of adrenal suppression and may not be able to mount the expected stress response after a surgical procedure. And so for this reason, depending on the type of procedure to be performed, steroid replacement, or sometimes called stress dosing, might be necessary. First of all, for minor procedures like endoscopies and hernia repairs, there isn't much of a stress response, and so no stress dosing is necessary here. For patients who are to undergo a moderate stress procedure, like a laparoscopic cholecystectomy, we'll generally give 50 milligrams of hydrocortisone right before induction of anesthesia, and then follow up with 25 milligrams IV every 8 hours for 1 to 2 days. After that, the patient can then resume their normal oral steroid dose. If the patient is due to undergo a much more stressful procedure, like an open colectomy, then we'll give a larger dose before induction, usually 75 to 100 milligrams, and then we'll give 50 milligrams IV every 8 hours for another 1 to 2 days, and then after that we'll back off to the normal dose that the patient takes. Once again, thank you for your attention. If you're interested, I've listed the URL for this course's website, which you can check out. And I have a number of other YouTube videos on basic surgical care that you can peruse as well.